we're going to be doing a general hand inspection. We're going to use my hand because I'm my own patient. But for my hand seems pretty normal. My wrist is slightly extended and my hand is slightly flexed. No deformities in my fingers whatsoever. There's nothing like ape hand where my thumb is parallel to my fingers. Nothing like swan neck or boutonniere deformities or anything like that. There is some slight scarring on my hand, if you can see. And my fingernails look a little jank. That's because I have a bad habit of biting them, but my lumina is still there in every single one of my fingers, so my fingernail will grow back. So yeah, overall, my hand's pretty normal. All right, so we're gonna do some manual muscle testing. Bear with me because I am my own patient, so it's gonna be a little bit weirder. Normally we'd have one hand stabilizing the forearm, but for me, it's not. We're gonna have this hand just act as the resistor. So first we're gonna do wrist flexion. We're gonna take this hand and put it in the meat of their hand, the patient's hand, and then we're gonna ask our patient to flex their wrist, and we're gonna resist them while they go through the motion. Perfect. And then for extension, same thing. Put on the meat of hand and then extend. Perfect. Next, we're going to do radial and ulnar deviation. Radial this way, ulnar this way. So to start, we're going to do radial. We're going to have them deviate radially. Perfect. And then ulnarly while resisting with this hand. Next, we have thumb flexion and extension. So for this one, normally you would also have one hand stabilizing the base of the first metacarpal, but again, we're just gonna have this hand just be the resistor. So imagine there's a hand right here stabilizing. The other hand for flexion, we're gonna put on the thumb and then have them flex. Same thing, we're gonna have them extend. Perfect, and then the last one is flexion and extension of the fourth finger, PIP. So for that, it's going to be this right here. Again, normally you'd have it like clawed like this with two fingers, but again, we're just going to try to, so bear with me, kind of stabilize the base of that PIP, and then put the other one on the other side of that joint, and then you have them flex that finger. Perfect. And then for extension, have them resist and then extend it. Perfect, and that's it. All right, so now we have some palpations. Again, we're just going to use my hands, so bear with me. First, we got the carpal tunnel. Take on the anterior side of the hand. It's going to be kind of this divot structure. It's made of lined with bones, tendons, ligaments, and just nerves. It's going to be right at the base of your hand. Then we have the hypothenar eminence, which again, anterior part of your hand, kind of the meat on the ulnar side. So most medial meat of your hand. Radial styloid process, take your radius, move all the way dorsally, just on the lateral part of your radius. Most dorsal and lateral part of the radius, and that's your styloid process. The scaphoid, extend your thumb on the posterior side of your hand, and in between these two tendons that stick out, ulnarly deviate your wrist, and there's going to be kind of a bone that pops into place. You can kind of feel it. You can also feel it on the anterior side. There's going to be a prominence of the scaphoid. You can kind of shift it back and forth, honestly. That's your scaphoid. The Lisser's tubercle. We're going to go back to this ligament that sticks out. We're going to kind of follow it. And on the radius, just medial of the styloid process, there's going to be a tubercle that kind of sticks out. It's easier if you have your wrist flexed. It's going to be right there. The hamate, hooking hamate, just go onto the palm side of your hand, and there's going to be prominence right here. Pretty easy, very prominent. First, metacarpal, that's pretty easy. Take your thumb, follow your thumb dorsally, all right, proximally, sorry, and it's just the bone right here. That's first metacarpal. Third, proximal phalanx. So your third finger is your middle finger. Proximal phalanx is just going to be the segment, the segment of your finger that's closest to you. So this is it. The thumb, ulnar collateral ligament. It kind of covers the first MCP. You can kind of dig in there. That's going to be the thumb UCL in there. The wrist, radial collateral ligament. Sorry, I can't pronounce words sometimes. Go to the radius. And it's going to be the most lateral part. If you kind of ulnar and radial deviate, you're going to feel this ligament really protrude out. Kind of connects to the styloid process. That's it. And then you have your triangular fibrocartilage complex going to the ulnar side of the wrist on the anterior portion, and it's going to be this right here, just all this. So that's your TFCC. So yeah, palpations. So we got some more palpations. So to start, we got the thenar eminence. So on the palm side of your hand, it's literally your palm. It's this meaty eminence right here. This is thenar eminence. We got the Guyon's tunnel. So similar to the carpal tunnel, which is like this structure. The Guyon's tunnel specifically is kind of at the base of your hand, but it's kind of a divot in there. That's the Guyon's tunnel. The anatomical snuff box, as we did when we were trying to find the scaphoid, kind of like extend your thumb. You're going to see these tendons pop out. This makes kind of a triangle structure. That's your anatomical snuff box. So you just palpate along that and there. The ulnar styloid process, the radial styloid process, go directly medially, and you're going to find the ulnar styloid process, the most dorsal end of the ulnar and the most medial end of the ulnar. So yeah, that's ulnar. The lunate. Lunate's interesting. So if you can find that bony prominence, follow it up distally and kind of medially, there's going to be a little divot. If you passively flex your wrist, you're going to see a bone pop up. That's your lunate. The trapezium, that's going to be at the base of your second metacarpal and kind of the base of your first metacarpal. Follow it all the way down. You're going to find trapezium. It's just above the scaphoid. The capitate's interesting too. It's aligned with your third metacarpal, so just follow it all the way down. You're going to see kind of a little bit of prominence right here, and that's going to be your capitate. You got your fifth metacarpal, pretty easy. Take your pinky, go at the base of the pinky. It's this bone right here, all up in there. The first distal interphalangeal joint. So we have our first finger, aka our thumb. The DIP joint just below your fingernail, point where your thumb bends. That's it. That's the DIP joint. Well, I guess, yeah, DIP joint. The fourth distal interphalangeal joint, take your fourth finger, that's your ring finger. It's going to be below your fingernail where your finger bends right here. This is going to be that joint specifically in the UCL of the third PIP joint. So yeah, that's just going to be, take the PIP joint, your third finger is your middle finger, and go on the ulnar side of your finger. And this is going to be the UCL of that PIP joint. So yeah. All right, so we got some more palpations. First, we got the flexor carpi radialis. It's easier if you just kind of flex your wrist. You're going to see it. It's the most lateral prominent tendon that sticks out. Follow it all the way down to the medial epicondyle. Next, we got the flexor digitorum superficialis. That's kind of hard to differentiate up in the hands, but they flex the hands. Follow it. There's 4. Boom. And again, just down to the epicondyle. And the extensor carpi radialis longus. So we're going to take our first metacarpal, go to the base of it, and that's where it is. We're going to follow it all the way down to the lateral epicondyle of the humerus. And then we have the palmaris longus, again, kind of same as the flexor carpi radialis, but it's the prominent ones that kind of sticks out. Easier when you radially deviate. It's this one right here, follow it all the way down. Some people have it, some people don't. I do have it. The extensor carpi ulnaris, so we're going to take right here, kind of on the ulnar side. If we just extend, for me, it's easier if I move my pinky. You can kind of see a little twitch, and that's what that's going to be. It's the extensor carpi ulnaris, the flexor carpi ulnaris. So we're going to go back on the palmar side of the hand. It's going to be where the hook of the hamate is. So if you just extend and flex the wrist, find it all the way down, keep on going on the ulnar side, and go down to the medial epicondyle of the humerus. Again, and then we have the adductor pollis longus and the extensor pollis longus. So for that one, we have the adductor pollis, which is, if we have that triangle shape again, this is going to be the adductor, and this is going to be the extensor. So yep, that's it. All right, so we got some range of motion measurements. This is Timmy, is going to be the skeleton. That's going to be helping me out for the ones that I can't do myself. So for this, we actually have a goniometer because we're at a clinic. But anyways, We have the ulna. We're going to align the stationary arm with the ulna and the fulcrum with the styloid process. Obviously, there would usually be meat on the arm, so the arm would be up a little bit more. So for that, we're just going to kind of hold it up to get it center of the styloid process. We'd have our hand stationing the forearm, and then the moving arm is going to be in line with the 5th metacarpal. And then all we're going to do is, starting at 0, we're going to measure flexion, 0 again, all the way to extension. We're going to take those measurements. So yep, that's it. And then that's passive range of motion, but for active range of motion, we just not be the one assisting the patient, but obviously the skeleton can't move on his own, so just do the same thing as we did just now, but have the patient actively move their wrist themselves. All right, so we're going to be measuring ulnar deviation for this. Again, we're going to use Timmy the skeleton. We're going to have the stationary arm aligned with the middle of the forearm. Usually, again, there's meat. We'd put the fulcrum or the center axis over the capitate, and then we're going to align the moving arm with the 3rd metacarpal. All we're going to do for passive range of motion is just move the wrist ulnarly. Same thing for active range of motion, but again, we just kind of hold it there, and then the patient would move his or her wrist by themselves without us assisting, and we just take the measurement. So yep, that's it. All right, so we got some hand movements. To start, we got flexion, extension, abduction, adduction, and then opposition. That's it. All right, so we're going to do some special tests. We're going to try to do it on me, as it's just a hassle to move the skeleton everywhere. So yeah, first off, we have our wrist valgus stress test. So we take our wrist. Normally, we'd have one hand stabilizing the forearm and the other hand over the palm of the wrist. So just imagine there's a hand over here stabilizing the forearm. We're going to take this hand, put it over the palm of the wrist, and then we are going to put a valgus force on that wrist. All we're trying to do is put a lot of stress on that UCL. UCL. A positive test would indicate if there's any pain elicited, or even like maybe popping or like crunching happening. The varus, and then next is the varus stress test for the second PIP. So we take our index finger, which is our second finger. PIP joint is this right here. All we're going to do is we're going to try to stabilize the proximal phalanx and also the kind of the intermediate phalanx. So imagine if I had 2 hands, just imagine. For this, we're going to stabilize and put a varus force on this joint. Positive test would indicate if there's increased laxity or if there's just pain elicited. Next, we have the hook of the hamate test. So for this one, we're going to have our palm facing up. Again, normally there would be hand right here stabilizing the forearm. So just imagine there's one. We're going to ulnarly deviate the patient's hand. We're going to ask them to flex their PIP and DIP joints of their 4th and 5th finger. And then all we're going to do is we're going to take our 2 fingers, kind of hook it around their fingers, and pull up as they try to resist. Positive test would indicate if there's increased pain over the hamate, just showing that there's possibly a fracture of the hamate. So yeah, Tinel sign, all we're going to do is just tap over where the median nerve is. If there's any numbness or sensations over kind of by the 1st, 2nd, and 3rd fingers, that side of the hand, that probably indicate there's a Tinel sign, and that test would be positive. Next is the phalanx test. You'd have a patient kind of flex their wrists and push them together, forcing them together, pushing against each other, and have them hold it like that for a minute. Just for time's sake, we're not actually going to do it for a minute. So 1, 2, 3, 59, 60. Wow, a minute. Basically, we would ask the patient if they've experienced any numbness or any weird sensation. This test would indicate there's probably some pressure over the median nerve, and that would be a positive test if there is numbness or numbness or sensation. We have the Allen's test, which is kind of a fun test. We're going to have our patient stick out their hand, and then we're going to have them open and close as fast as they can. And then we're going to tell our patient to make a fist and squeeze for about 30 seconds. And then after 30 seconds, you'd put both of your thumbs over the radial and ulnar artery, but we're just gonna imagine these are the two thumbs. We're gonna push it over there, push it on there, and we're gonna ask your patient to open their hands. You can see there's no blood flow. And then we're gonna take one of our thumbs off the radial artery, and you can see blood flew back in the hand as the hand changed color. We would repeat that process for the ulnar artery as well. Boom, blood flew back in. Positive test would indicate if there was not blood flow back in, or it took a very long amount of time to get blood flow. That'd just be decreased circulation. So yeah, that'd be a positive Allen's test. And then we have a Finkelstein test. We'd ask our patient to make a fist around their thumb, clamping the thumb, and then kind of ulnarly deviate, or putting pressure on this tendon right here. Positive test would be if there's any pain elicited. This test often produces false negatives, as you can kind of already feel a stress on there, but it is normal to feel a stress, but it would be more if there's a very explicit and very elicited pain, like it really, really hurts. That'd be a positive test. And the last one, we have a thumb valgus test. So for this one, imagine there's a hand stabilizing that first metacarpal. Yeah, so just imagine. And then the other hand, we're going to kind of put on the proximal phalanx. And all we're going to do, so yeah, imagine that, is we're going to apply I don't even know how to do this one, kind of without the thing. Hands right here. Apply a valgus force on the thumb with stabilizing this. And then a positive test would indicate if there's any pain elicited over that UCL of that thumb. That's all we're trying to do there. So yep, those are the special tests. Okay, we're going to do some manual muscle testing. It's going to be a little bit harder because you're going to be the patient and the physician at the same time. So to start, we're going to have our arm supinated, and we're going to do manual muscling for flexion. So we're going to put a force right here. Normally, hand would stabilize the elbow. Put a force, resist against flexion for the biceps brachii. Then we're going to pronate our arm, resist against flexion for the brachialis. And then mid position, we're going to resist flexion for the brachioradialis. Now for elbow extension, normally you'd have a patient laying down trying to extend their elbow, but we're going to kind of mock that. Apply force, try to extend, 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 extend. Good. And then for pronation and supination, we're going to start in a supinated. For pronation, we're going to apply resistance against pronation. Good. And then for supination, good. All right, so we got some elbow palpations. First, we got the elbow posterior triangle. Posterior. It's kind of hard to palpate on itself, but we have the medial and lateral epicondyle with the olecranian process. All we're going to do is, as you can see, it kind of makes a triangle. So yeah, that's the triangle. The cubital fossa, take the anterior part of your arm at the elbow where the joint line is. It's going to be kind of the divot in. That's the cubital fossa right in the middle of your arm. The olecranian fossa is on the posterior side, where the radius and the humerus kind of pivot. If you flex your arm a little bit, like 50 to 70 degrees flexion, there's going to be a little divot right in there. That's where the radius kind of connects with the olecranian, the humerus, sorry, and that's where the fossa is. Medial epicondyle, right here, humerus, it's pretty prominent. Same with the lateral epicondyle, pretty prominent. Can't miss them. Radial head, go to the lateral epicondyle and kind of move distally, sorry, and you're going to kind of feel this bone. If you pronate and supinate, it's easier because you'll feel that radial head kind of move, and that's where you know you had that radial head. Next, we have the ulnar shaft. That's pretty easy. Here's the ulna, and then kind of just move along it where you feel the bone, and that's the ulnar shaft. It's going to be that middle portion. Humeral shaft, humerus, and just kind of squish your muscle. When they relax, you're going to feel that bone, and that's going to be the humeral shaft. We got the ulnar groove. It's where your ulnar nerve runs through. It's where you hit your funny bone. But it's going to be between the olecranian process and the medial epicondyle. It's going to be that little divot, that groove in there. The elbow, UCL, medial portion of your elbow flexed. It's going to be all right here where your humerus connects to your ulna. This is going to be the UCL. Intercilious membrane, sorry if I mispronounced that. You can't palpate that directly, but you have your ulna and your radius. In between both of these bones, there's kind of a membrane connecting them together along this. So when it moves, it kind of, yeah, you get the point. The biceps insertion, here's the biceps. Follow it, follow it. You're gonna feel a very, very tight tendon move all the way in. It's gonna insert in here. So that one's pretty prominent either. Pronator teres. Pronator teres, that one's pretty easy as well. So medial side, I like to pronate and supinate. It kind of makes it a little bit easier on me, but it's going to be like this muscle that you can kind of feel, especially when you pronate. That's why it's called pronator teres. Just kind of follow it. That's the pronator teres. The brachioradialis, that's going to be the bulk of your forearm. So just kind of follow it on the lateral edge of your arm. It's easy. It's hard. It's easier to see, kind of. Hopefully you can see it when there's resisted flexion. That's brachioradialis. And then the last one, we have the triceps brachii. This is the triceps. Kind of makes a horseshoe shape, hopefully. I don't really have big biceps like some of these bodybuilders, but yeah, that's it. So I think that's it on the thing. So yep. Brief overview of the nerves. All right. First, we got the radial nerve, pretty crucial nerve. So to start, hopefully you can see it. Start in the armpit. It's kind of getting wrapped around the humerus. Rise at the elbow. Kind of follow the radius afterwards and into your little fingers. This is a pretty crucial nerve. It's responsible for a lot of the extensors, the adductor pulse longus, and stuff like that. Brachioradialis. So yeah, pretty crucial nerve. Next, we got the median nerve. Kind of just median portion up, medial nerve, middle portion of your arm all the way up. This is responsible for a lot of the wrist flexors. You can see it's kind of this portion of your hand. It's mostly responsible for. So yeah. And then we have the ulnar nerve. Armpit goes into the ulnar groove, aka your funny bone. Follow the ulna all the way over here. This is more for this part of your hand. A lot of flexion on this hand, like flexor digitorum or your flexor carpi ulnaris. It's going to have the flexors on the ulnar side of your hand. So yeah, kind of just a brief overview. Yep. All right, so we're going to do active and passive range of motion for elbow flexion and extension. So to start, we got Timmy. He's kind of decapitated right now. Just ignore that. We're going to take our goniometer. Whoops, sorry. Put the stationary arm over the humeral shaft along with the acromion process, and the fulcrum is going to be on the lateral epicondyle. The movement arm, we're going to align with the radial, the radius, sorry, and its little point that it's going to be with is going to be the styloid process. All we're going to do is we're going to move the patient's arm in flexion and back to extension, and we're going to take those measurements. That's passive range of motion. Obviously, we can't do active range of motion because this is a skeleton. Active range of motion, all we're going to do is just hold it there and have the patient actively move their own elbow. So, yep, that's it. All right, so we got some elbow special tests. For the first one, we have elbow valgus stress test. Again, bear with me because this is a skeleton and not a real person. We're going to have our patient put their arm in a flexed position. With this hand, we're going to support the lateral portion of their forearm and then wrap our hands around to the medial portion of their forearm. And then with this hand, we're going to put on the distal aspect of the forearm and apply a valgus force. All we're trying to do is just stress the medial portion of the elbow. If pain is elicited in that area, that would indicate a positive test. For the next one, we have tennis elbow. We put our patient in a pronated, with their arm pronated. We're going to resist wrist extension while we're also palpating the lateral epicondyle. If pain is elicited in the lateral epicondyle, which is the common origin point for a lot of wrist extensors, that would indicate a positive test. Next, we have the hook test. For this one, it's a little bit harder. but we're going to have our patient in a flex position, and then they're going to resist supination. And then all we're going to do is, as an examiner or physician, as they're resisting supination, we're going to try to hook their biceps tendon along its insertion. If we can't hook it, that would indicate a positive test, and that would likely indicate a tendon rupture or tear or something of that nature. Bicep squeeze test. Just gonna move this. For the bicep squeeze test, all we're gonna do is we're gonna take, imagine the physician on this side. He's gonna grab two hands. He's gonna grab the biceps. I'm going to pronate my arm, and then the physician is going to squeeze my bicep, and you should see slight supination of this arm. That would indicate that'd be a good test. But if there's not any supination when squeezing, that would indicate a positive test. So yeah, and then I forgot to say, but the arm is flexed slightly, just slightly, not fully flexed. But yeah, for the Tinel's test, the physician is going to go over to the ulnar nerve, right by the ulnar groove. They could take some tool like this and just kind of tap over that area and see if the patient exhibits any sensation, something like that. If pain's elicited in that area, that would indicate a positive test. And for this last one, hopefully you can see it. We're just going to get this guy down here. Yeah, do the best we can. We're going to have our patient like this. And as a physician, we're going to put one hand on their elbow, on the medial portion of their elbow, and the other hand on the distal forearm, and we're going to externally rotate their shoulder with this arm slightly extended. And then we're going to apply a valgus test while we are putting the arm into flexion, like that. If pain is elicited, that would indicate a positive test. But yeah, that's the moving valgus stress test. But yeah, that's it. Okay, so we got some shoulder palpations. So to start, we're going to find the bicipital groove. We're going to externally rotate our shoulder. We're going to look for a little divot. Okay. Yeah, found it. That's going to be the bicipital groove. Lateral, we move laterally. That's going to be the greater tubercle. There again. And then move medially from the bicipital groove. That's going to be the lesser tubercle. In the bicipital groove, that's where the long head of the biceps is going to originate from. And if we move medially, or let's go to the most divotal point of the clavicle, move about a finger down. You're going to find the coracoid process, and that's where the short head of the biceps is going to insert on. Follow that. That's where the short head of the biceps insert. If we follow the little divot, that's where the long head of the biceps is going to insert. So, yep, that's it. Okay, so we're doing the cranial nerve assessment. Bear with me. I'm going to act like the patient and the physician. So yeah, let's get started. CN1, smell this for me. What does it smell like? Sweet. CN2, how many fingers am I holding up? 2. CN3, we're going to act like this is the light that goes over the pupil. Cover one eye, put the light over. See if the pupil contracts or dilates as needed. For that, sir, I'm also going to have you raise your eyebrows for me. Follow my finger. CN4, CN6. For CN5, I'm going to have you chew with your mouth closed for me. Cool, stop. Can you feel that? Yes, sir. For CN7, I'm going to have you smile for me. Make frowny face, puff out your cheeks. Cool. And, whoopsies, sorry. For CN8, I'm going to have you close your eyes and stand on one foot. Me acting like I'm standing on one foot. Cool, stop. With your eyes remain closed, can you hear this? Yes, good, open your eyes. CN7 and CN9, taste this for me. What does it taste like? Salty. For CN9 and CN10, I'm going to have you swallow for me. Good. For CN10, I'm going to have you cough for me. Good. For CN11, lift your shoulders. Put them down. Look left, right, and then up and down. For scene 12, I'm going to have you stick out your tongue. Good. You've completed the assessment. Good job.